Be done at Akshay. I'm going to be talking to you about single position OLIF with lateral MIS instrumentation. There are many ways to perform the lumbar interbody fusion. It can be done as a posterior approach in either the conventional or the MIS techniques, or it can be done as an anterior approach, or it can even be done as a lateral approach. Well, each of them have their own unique advantages and disadvantages. While the posterior approaches have some amount of nerve root handling and paraspinal muscular dissection, the anterior approaches have the potential for the retraction of an injury for the great vessels, and the lateral approaches have the potential for the lumbar plexus injury as well. So the OLIF approach was actually designed as an intermediate between the anterior and the lateral approaches, with overcoming both of their complications. However, it required the anatomical window between the psoas and the great vessels. Today it has become a very common approach, especially for treating various types of degenerative lumbar conditions wherever fusion is required. Being performed in the lateral position, conventionally it requires a repositioning for placement of the percutaneous screws. This increases the OT time as well as the anesthesia time. However, with the advent of OARM and navigation, nowadays these screws can be placed safely in the lateral position itself with improved safety and accuracy, as it has been reported in the literature. And we are here by presenting our experience with the single position OLIF technique, and this is what I'm going to be talking about today. So this was a patient who had a severe lumbar canal stenosis and a grade 1 listhesis and a feasible anatomical window. Patient is positioned in the lateral position and properly strapped and supported, and patient is placed in the absolute edge of the bed so as to place the screws even on the right side. The PSIS is located and the percutaneous pin is placed on the PSIS for the reference frame for navigation. The OARM is then brought in, and the three-dimensional images are automatically registered. And using these images on the navigation, the screw trajectories can then be planned. After the skin incision, the pedicle access is done using the navigated Jamshedi needles. And as you can see, the guide wires can be placed in this manner, and both the right as well as the left-sided guide wires can be placed using this manner. Subsequently, the OLIF skin entry is marked using the same navigation, and as you can see, the simultaneous working of two surgeons, while one surgeon is performing the dissection for the OLIF screws, can be placed in the lateral position simultaneously. Subsequently, after the placement of the guide wires, the OLIF can be completed using the microscope in the standard fashion as described previously, and the cage is also placed using the orthogonal maneuver. Once the OLIF is completed, as you can see, the closure can be performed by one of the assistants, while the navigated dilatation and tapping can be performed simultaneously as well. This saves operative time and improves the efficiency of the overall workflow. Once the final screws are placed, the rod can then be inserted, and this is the only step that cannot be done under navigation and requires the CM guidance. And once the rod is also inserted bilaterally, you can see these are the final images. So this was our experience from 2019 to 2024. A total of 75 patients were operated upon, and 92 operative levels were performed in the single position. These are mean operative times for single level, 2 level as well as 3 levels. And at the end of the procedure, a final OARM spin is taken and the intraoperative data is collected. So what you can see over here is that we have compared the navigated screw trajectories by using the screenshots which are saved at the time of navigation, and the final OARM spin as well. The surgical screw angle as well as the axial screw angle is calculated, and the difference between the actual screw angle as well as the virtual screw angle is then calculated. 362 pedicle screws were performed in the single position OLIF technique, and the accuracy was reasonably very high, almost 99.5%. So there is not much evidence in the literature, and as you can see here, it's only over the past few years that this particular technique has been started to be described. So as early as 2018, the first article of this kind of technique was published as a feasibility study, and they had very clearly concluded that there was definitely improvement in the operative time as well as the overall efficiency. So the most recent article was published last year in Nature, and they also found that this single position OLIF technique significantly reduced surgery time and improved the overall accuracy of the pedicle screw placement. So the take home is that this single position OLIF technique, there is no need for repositioning, and it reduces the overall operative time, anesthesia as well as costs. There is reduced radiation because a single OARM spin can be used for both the OLIF as well as the screw navigation, and there is overall better surgical workflow. Two surgeons can work simultaneously, and improving the overall efficiency as well as while retaining the accuracy. However, there is a little bit of learning curve that is required in this particular technique because of an orientation and working in the lateral position for the screw placement. Thank you.